Assalamu alaikum. Good evening, ladies and gentlemen. This is Mohammed Mamoun, Lokelma brand manager of AstraZeneca Saudi. At the beginning, and on behalf of AstraZeneca, I would like to welcome all the online attendees for today's webinar. Actually, this scientific gathering was built to discuss one of the most interesting and important topics, which is the management of hyperkalemia and recent updates in management of hyperkalemia, especially in CKD and heart failure patients, and the role of Lokelma as a new hope and a new path of hyperkalemia management, especially after its approval in Saudi Arabia. For that, we are privileged. We have the honor to have two special guests with us today. Professor Stephen Fishman. Professor Stephen is a well-known global figure, a global speaker. Professor Stephen is a professor of medicine at Donald and Barbara Zucker School of Medicine at Hofstra, Northwell, USA. He is also the chief of the Division of Kidney Disease and Hypertension at Hofstra, Northwell School of Medicine in the USA. Professor Stephen lecture will discuss the recent updates in management of hyperkalemia in CKD patients. After that, we have the honor also to host Professor Mark Petrie. Professor Mark Petrie is a well-known reputed global speaker. Professor Mark is a professor of cardiology at the Institute of Cardiovascular and Medical Sciences at the University of Glasgow. He is also a cardiologist at the Golden Jubilee National Hospital and the Glasgow Royal Infirmary in Glasgow, UK. After that, we'll be having the Q&A session. So if you have any question for Professor Mark or Professor Stephen, just use the Q&A button at the bottom of your screens to ask the professors, and your question will be addressed at the end of the presentation. So before we start our meeting today, let's start by a quick survey, a quick poll to know your thoughts, your reflections, and how you feel about hyperkalemia management and the current situation in Saudi. So, Ustaz Anura, if we can start the poll. We encourage all the online attendees to answer the poll. The first question, or the first point we need to survey: how do you see the current gap in hyperkalemia management? There is a huge gap, average gap, we still can manage potassium levels with the current treatment options. There is no gap at all. How do you see the current gaps, or how do you see the current management of hyperkalemia in our region? Second point, do you believe that there is a current need for a chronic potassium binder used in heart failure and CKD? Second question, there is a current need for a chronic potassium binder used in heart failure, CKD, hyperkalemia patient, yes or no? Regarding the Rassi inhibitor use, do you see the challenges in optimizing the Rassi inhibitor therapy or dose while managing CKD and heart failure patients? The last point, do you have any previous experience or have you ever heard of Lokelma, sodium zirconium cyclosilicate? So as you can see, professors, the majority of the audience either see there is a huge gap or there is an average gap. We still can manage the current potassium level. About the belief that there is a need on the use of a chronic potassium binder in heart failure or CKD hyperkalemia patient, yes, 88% of the audience agree that there is a need. Regarding the challenge in optimizing the Rassi inhibitor dose during the management of CKD or heart failure, 88% of the audience agree that there are challenges in the management of the Rassi dose. Regarding the Lokelma, 60% or 59% of the audience, this is the first time to hear about sodium zirconium or Lokelma, because as you know, this is the first meeting in Saudi Arabia to discuss the role of Lokelma as a new hope for hyperkalemia. So, Professor Stephen.
Well, it's a pleasure to be able to speak to you today about hyperkalemia management in patients with kidney disease. We'll be going over the spectrum of care today, and I want to note that I have certainly done research and consulting with AstraZeneca. So let's start by thinking about how frequent hyperkalemia is. This was a study by Betts and colleagues. The blue line at the bottom shows that in the general population, that hyperkalemia, of course, is a relatively uncommon occurrence. But as we jump up to the gray line, you'll see that in people with CKD or heart failure, that it actually becomes 5 to 6 times as common. So it's an important issue in the patient populations of interest for us. A number of factors affect hyperkalemia. So age has always been an important factor, probably related to just the accumulation of comorbidities that put patients at risk. GFR, the advancement of chronic kidney disease, goes along with an increased risk for hyperkalemia. Diabetes, important, doubles the risk. Patients who've had a myocardial infarction, I always find this one kind of interesting. With heart failure, you'll hear more about this, and certainly with Rassi therapy, ACE inhibitors, angiotensin receptor blockers, and mineralocorticoid receptor antagonists, there is an important increase that can be managed. When we think about hyperkalemia, this was work by Chava-Kubetsky et al. That related the risk for mortality on the y-axis with different just routine levels of serum potassium. And Chava showed that as you got to potassium levels, especially above 5.3, but I think it became significant when the potassium was above 5.6, that there was an important increase in the risk for death, which obviously increases further as you get to higher potassium levels. And when I first saw this, I asked myself, at a level of 5.6, why would there be an increased risk of death? But I think the point is that it's not that day when the potassium is 5.6, but for people who have demonstrated that potassium runs at a higher level, they're going to have some other day in the future where they've had more potassium intake. They've been at some social event, or their diet has been different for a day, and they've eaten foods. This, I think, is kind of a signal that if you've been 5.6, 5.7, at one point, you're the person who will be at 7 or 7.5 at some other date. So a nice relationship, it's important for us to understand. So we'll go directly into hyperkalemia treatment. And currently there are 3 binders that are available for use. So sodium zirconium cyclosilicate, which is Lokelma. In the US, we still have SPS, so that's available, has been available for probably 50 to 60 years at this point. And in the US, we have Terramere available. The agents are somewhat different. I would like to point out, Lokelma is interesting because it starts to work not in the large intestine, but rather in the small intestine, and therefore it has the interesting property that we'll come back to, which is that it works fairly early in terms of lowering potassium concentrations. There's no calcium content with this agent. There is sodium content, about 400 milligrams per 5 grams of Lokelma. We'll talk a little bit more about this. That doesn't mean that amount, of course, becomes absorbed. Adverse events, we do see some edema. We'll come back to that with Lokelma. With SPS, there's a whole bunch of different effects that are important. The one that really interests me is just non-selectivity, the fact that it kind of binds to everything and slightly different for Terramere. And for starting doses, dialysis, really interested in the fact that Lokelma is available for the treatment of patients on dialysis where problems related to hyperkalemia are particularly important. So the structure itself, which you're probably aware of already, this is a crystalline compound. So, we're used to thinking about things like SPS that are large polymers, but rather this is crystalline, and it has a pore size that allows it to trap potassium that is almost the exact size, 3 angstroms of a potassium molecule. And that's fascinating. It gives it exactly the right size to get specificity so that it binds potassium. There's exchange, so it releases both sodium and hydrogen ions for potassium. The hydrogen ions, no issue, because that essentially turns into ammonium, which gets absorbed back by the compound. So serum bicarb concentrations actually increase repeatedly in the studies that have been done. So the specificity, I think, can be shown really nicely. So in the initial studies, Lokelma was called ZS9, and you'll see here that the exchange capacity for potassium is very, very high compared to SPS, which is what we had for treatment initially. And that kind of specificity, and the specificity compared to that for grabbing other molecules like calcium or magnesium or medications for that matter, is a really important difference in terms of the properties of this agent. So the first study that really looked at the agent carefully, Mikhail Kosovarod, a group of investigators, including nephrologists and cardiologists, looked for 28 days, and they showed that using the agent at an initial dose of 10 grams 3 times a day. Now, that's not the way that I typically treat in chronic treatment, but there is a very nice acute decrease in the potassium concentration. And as they tested different concentrations of Lokelma, they found that compared to placebo, so the top here, the potassium of about 5.2 is placebo, and at different concentrations of Lokelma, there is a dose-dependent reduction in the potassium concentration. This went to 29 days. Now, I'll call your attention to the fact of something that became interesting very early as Lokelma was studied, and that's that it not only reduces potassium, but because it starts to work. So you take it, gets into the stomach, into the duodenum, but it starts to work very early in the GI tract. And as a result of that, if you look very carefully here, we're looking at hours 0 to 4 hours. And within 1 hour, the potassium has already come down by about 0.3. By 2 hours, it's come down by 0.5, at about a little bit more than that at 3 to 4 hours. So this is a rapid acting agent. So we're really interested in that right now. We've got about 750 patients that we've treated recently in our emergency department, and we're putting together some of that experience. Now, I do want to note here, it's of interest for us in the US that when we compare it to the other agent that is used a lot, which is Terramere, that's an agent that doesn't really start to work until about 4 hours, where you get a decrease from about a 5.9 potassium to about 5.8. So really not much of an effect. I mean, it's 7, 10 hours, 12 hours, you start to get the effect. But again, that's really different. So it's an important difference in the properties, and this may not be important to you between the two drugs, but I think it's really helpful to think about because we've certainly leveraged this. So if I get called at 4 o'clock in the afternoon and I have a patient whose potassium is running high, I know I can give Lokelma to them and get a rapid decrease in potassium, often avoiding an emergency department visit. In this study, looking at adverse events, the drug, it's a helpful study to look at because it's compared to placebo. So really a very similar event profile compared to placebo, except one thing, that there was some edema. Remember, there's a little bit of sodium that gets absorbed. So in the placebo group, 2.4% of patients had an adverse event reported for edema. It's obviously not caused by the placebo, it's this population of patients. The 5 milligram dose of Lokelma, the number is about the same. It's 2.2% in this study. At 10 grams, it rises to 5.9% compared to 2.4%. It's at the 15 gram dose where I think we sometimes see issues, and here it was 14% compared to 2%. Really interesting is that when you think about treating patients with something that binds potassium, you worry about the risk potentially for lowering excessively the potassium concentration. But this is good to know, so that if you start at a relatively low potassium concentration, the reduction in potassium is substantially less than when you treat with Lokelma at higher levels of potassium, where you get a greater increase. That kind of makes sense, but it also gives you a good, I think, reassurance that your risk for inducing hypokalemia would be quite minimal. So trying to go beyond initial studies of 48 hours or 29 days, we did a study where we looked at 1 year of treatment. This was open label with Lokelma, and we saw again that there is a really nice initial reduction of potassium, but here now we're looking at weeks. So are you able to treat somebody chronically, as we often do in practice, to treat chronic hyperkalemia, to be able to optimize, for example, doses of ACE inhibitors or angiotensin receptor blockers, MRAs, over the course of 52 weeks, no real change, that you get that really nice benefit in terms of reduction of potassium, and that continues with very good continuity right through week 52. There's no loss of effect with this agent over the course of time. So when we look at hyperkalemia with Rassi treatment, I think this is where things become very interesting. I think both in cardiology and for cardiologists treating heart failure and some other conditions, we try so hard to optimize dosing of ACE inhibitors, ARBs, and mineralocorticoid receptor antagonists. And they all have a predisposition to increase serum potassium. There's been so many studies that have shown that Rassi treatment tends to get backed off by the development of hyperkalemia. So people decrease the dose or they stop treatment. In hospitals, we frequently see it that somebody becomes hyperkalemic and the angiotensin receptor blocker is stopped completely and not restarted at discharge. This is true for all of these agents. I don't think there's a lot of difference. There has been some discussion about finerenone recently that we could talk about. But this is a really nice opportunity because potassium binders can be used to prevent discontinuation of these agents and to optimize dosing. And this was an analysis put together from Simon Roger, Bruce Spinowitz, where they looked at a couple of the key studies with Lokelma, and they found that 89 to 96% of patients continued their Rassi therapy, that for about 74 to 78% of patients, they maintained the same dose. There was no dose reduction needed. In fact, in 8 to 13%, the Rassi dose was actually increased during the course of study. In one of the studies, there was no reduction in Rassi dose. In the other study, 14% of patients, there was addition or switches of Rassis in some patients. And interesting, you know, patients who are naive to Rassi's, I'm not sure why that would even be in this population, but there was some initiation during the studies. And, you know, I think that what we can conclude when we look at the totality of data is that the use of Lokelma allows us to maintain Rassi doses. And when used, I think, carefully with the patient, understanding what you're doing to optimize treatment for heart failure and for preservation of kidney function over time. So let's talk about hyperkalemia now in the hemodialysis population. So this is a population that I was really interested in looking at hyperkalemia. It's common in our patients. It's intermittent, comes, goes, because patients tend to treat 3 times a week, say Monday, Wednesday, and Friday. You get a long interdialytic interval from Friday to Mondays, of course. And that 3-day period, it's not just a longer period, but it tends to be over the weekend. That's a period where people tend to eat more. Maybe they're getting together with family or restaurants, more input of potassium, so that the worst accumulation of potassium or hyperkalemia development is with the long interdialytic interval. But as you know, it's seen throughout the week in dialysis patients. So current treatment is dietary counseling, which, by the way, you know, I think there's a lot of skepticism these days. I think it is important for dietitians to work with patients, and yet we're starting to see data now that questions whether the diet advice that we give to patients is necessarily the right advice. We see medication adjustments, so reduction of angiotensin receptor blockers, for example, changes in the dialysis prescription. And then we have available the use of Lokelma for patients on dialysis. So we're seeing a real surge right now in treating patients to be able to reduce some of the risks. The data that supports this comes out of a study called the Dialyze Study. So these were patients who are on dialysis who had hyperkalemia in the long interdialytic interval, and it was simply a 1-to-1 randomization of Lokelma, sodium zirconium cyclosilicate, versus placebo. I would like to note it's 5 grams dosed on non-dialysis days and titrated upwards, and then a stable dose maintained, ultimately to look at achieving potassiums in the 4 to 5 range after the long interdialytic interval, so getting rid of hyperkalemia. When we look at the primary endpoint, it was quite stunning that with this regimen, the primary endpoint of lowering the potassium of 4 to 5 was achieved in 41% of patients with Lokelma, and in only 1 patient in the placebo group. There was a sensitivity analysis conducted, which really wasn't necessary. This is such a sharp magnitude of effect that it was clear that this was a highly effective way to treat hyperkalemia for people on dialysis. Interesting, you know, when you look over the course of time, so this is the pre-dialysis concentration of potassium, which dropped from about 6 to about 5, but we collected post-dialysis potassium concentrations, which, if you've never looked at post-dialysis potassium concentrations, it is worth noting, you know, the amount that potassium drops from before dialysis to after dialysis. That has nothing to do with Lokelma, that's just dialysis. But the post-dialysis concentration did decrease a little bit, not to any significant extent, but we'll come back to this subject and both the importance of hyperkalemia, but also the rapid shift of potassium. What does that do to the heart during the dialysis treatment? In terms of adverse events, we were really concerned in this population, but in fact, Lokelma really turned out to be just very similar to placebo. We didn't see any adverse events that were increased with Lokelma. This is in hemodialysis patients compared to placebo. When we looked very carefully at fluids, so if there's any population where sodium accumulation could be an issue, what we found here was that no, that this didn't occur. So looking at interdialytic weight gains from baseline going out to day 57, so 2 months of treatment, and the interdialytic weight gain stayed about the same. So there was no difference observed, no difference in edema, no difference in weight gains, no difference in other markers for fluid. When we looked at bicarbonate, we saw here an increase, not as much as we see in the CKD population. And if you worry about pre-dialysis hypokalemia, there were 5 patients in each group, 5 in the Lokelma group and 5 in the placebo group, who had pre-dialysis hypokalemia less than 3.5. So very pleased by this study with really clean results. So effective demonstration that Lokelma is highly effective for treating hyperkalemia, and very happy to see that it was really well tolerated in this patient population. So I want to finish today by just speaking a little bit about the importance of understanding what goes on with our patients. So this is a population of patients that has a tremendous number of cardiac arrhythmias. It's a major issue, and this is really nice work by Prabir Roy Chowdhury, who showed that HD1, the first dialysis of the week after the long dialytic interval, the number of clinically significant arrhythmias was much higher than the rest of the week. And then after that first treatment, as you start to go into the second treatment, the number of arrhythmias increases again before the second dialysis. Makes sense. As you start to accumulate potassium or other toxins, again, you get the issue of an increase in arrhythmias. You do the second dialysis, and before the third dialysis of the week, again, the concentration, the number of arrhythmias goes up as you get accumulation of potassium or water or other toxins. But it is especially before the long interdialytic, and at the end of the long interdialytic interval, going into the first treatment of the week, arrhythmias go way up. And during that first dialysis, arrhythmias go way up. So I think it's both accumulation, maybe of potassium, plus the rapid reduction of potassium during dialysis that may be related to the types of arrhythmias that were seen in this study, which I think are really interesting. So a current study that is ongoing is the Dialyze Outcomes study. Perhaps you have patients that are enrolled in this study. This is over a 2,000 patient global study, looking again at patients on dialysis whose long interdialytic interval potassium is greater than 5.5. It's a 1-to-1 randomization of Lokelma versus placebo. And the primary endpoint here, so this is a cardiac outcome study looking at sudden cardiac death, very common in this patient population, probably related most to arrhythmias, to stroke. So atrial fibrillation, very important in this population. Might there be a difference in stroke? Or hospitalizations and interventions, emergency room visits for arrhythmias, AFib, bradycardia, asystole. Remember, the bradyarrhythmia is very, very common in this population. Ventricular tachyarrhythmias. As of February 8th, so this week, about 25% enrolled. This is going to be a fascinating study to show us if the accumulation of potassium and the arrhythmias that go along with accumulation that we just looked at can be managed and reduced with treatment with Lokelma. So this study is really interesting. And I think there's 2 points. One, accumulation of potassium does it help to be able to reduce that. But remember, in binding potassium with Lokelma, we're also shrinking the gradient between pre and post potassium. So it's not as big of a flux, not as rapid of a reduction in potassium. Going to be fascinating. So in conclusion, remember that hyperkalemia is very common in the kidney disease population. It's linked to mortality and other outcomes. It's been a revelation in recent years. The treatment with potassium binders like Lokelma are highly effective for treatment in this population. Hyperkalemia is readily treatable even in dialysis patients with Lokelma, and that hemodialysis patients with arrhythmias may be manageable and this huge burden may be treatable. So we'll end with two quick cases. A 56-year-old man has heart failure with reduced ejection fraction, CKD with a GFR of 32 mLs per minute. So it's pretty advanced kidney disease, stage 3B, almost stage 4. Increased trouble breathing over the last 3 months. The medications have been adjusted with some benefit. He's on spironolactone, metoprolol, the combination of valsartan and sacubitril. Torsemide was added as with a potassium supplement. And then on February 3rd, 2 weeks ago, the patient was admitted to the hospital when routine office testing found the potassium to be 7.7. So there's no voting on this, but I would like to ask you to think about it. What contributed here? Was it the CKD, spironolactone, metoprolol, potassium supplement, valsartan, all of the above? You know, I sometimes think to myself that when you're taking a test and they offer you all of the above as an answer, it's very often going to be the right answer. But yes, I mean, in this case, as in a lot of people with CKD with heart failure, there are a lot of different factors that are all pushing the potassium level upwards. So in this case, yes, it would be all of the above. And in my final case, it's a 79-year-old man with diabetes and proteinuria. The GFR is 70, been treated with an angiotensin receptor blocker, losartan. And during a hospitalization for COVID a couple of months ago in December, he had 2 days with hyperkalemia. Now, this led the losartan to be discontinued, the angiotensin receptor blocker. He recovered, was discharged without the losartan. So which is most true? After an episode of hyperkalemia, that ARBs are chronically contraindicated because of the hyperkalemic episodes, losartan shouldn't be restarted, but instead ACE inhibitors should be used. 3, losartan can be restarted and a potassium binder used if needed to protect against hyperkalemia. And a low sodium diet should be initiated to prevent hyperkalemia. Losartan should have been continued since the hyperkalemia was acute. So no, when you have bad hyperkalemia, it's totally fine to stop the ARB. Low sodium diet, no, that will actually probably increase hyperkalemia. After an episode of hyperkalemia, chronic contraindication, no, we should come back. International guidelines and guidelines from different countries say come back, recheck, and restart the ARB. Because of the hyperkalemia, instead of losartan, you should use an ACE inhibitor. No real difference between ACE inhibitors and ARBs in terms of hyperkalemic risk, but 3 is the right answer. So losartan should be restarted, and use a potassium binder. Use the potassium binder to reduce the risk, and it gives you that chance to optimize treatment. Thank you so much, and I'll look forward at the end to answering your questions.
Thank you, Professor Stephen. Thank you for the great presentation. It was a really comprehensive and fruitful presentation. Actually, we got a lot of questions, and hopefully at the Q&A session, we will answer all the questions. Now for our second guest speaker, Professor Mark, over to you.
Thank you, Mohammed. What a fantastic lecture by Professor Fishbane. I'm really looking forward to the conversation we're going to have at the end, and hopefully receiving and answering many questions from the attendees and participants. So I'm now going to focus on the management of hyperkalemia, but I'm going to specifically focus on patients with heart failure and data from trials with respect to heart failure, and also data with respect to hyperkalemia and heart failure. So Professor Fishbane has eloquently told us really what we're here today to talk about. And these are these two new agents. So both Lokelma and also Veltassa, or SZC and Terramere. We've heard very clearly from Professor Fishbane that these are non-absorbed potassium binders which work in the GI tract, the gastrointestinal tract. SZC exchanges potassium for sodium, and Terramere potassium for calcium. I think we'll come back to that later in my talk and also in the discussion section. So I'm going to frame my talk into three different areas. First of all, the rationale for the use of potassium binders in heart failure. Secondly, I'm going to talk about the guidelines, which are quite remarkable actually. And then I'm going to talk about the clinical trials so far that have looked at the role of potassium binders in heart failure. So Professor Fishbane has already highlighted this issue, and really the big question here is, what is hyperkalemia? And if we talk to physicians or cardiologists in Europe or United States or in Asia or in the Middle East, I think people might have different perspectives as to which level of potassium represents hyperkalemia. Certainly in a lot of the trials, over 5 is regarded as hyperkalemia. And in clinical practice, I think personally, I regard hyperkalemia as over perhaps 5.5. And when the potassium rises to above 6 or 6.5, we certainly are more alarmed. But again, this is a fascinating area, and certainly talking to my renal physician colleagues, we learn what level of potassium they're concerned about. So I think we've seen many areas of cardiology and nephrology where we've learned a lot from each other. I think this is another great example where we can listen and learn. But I want you to all think about what level of potassium you regard as of concern. Heart failure, again, is an incredibly important disease state in which to consider hyperkalemia and indeed potassium homeostasis. Professor Fishbane has already told us about the kidneys and how important the kidneys are in hyperkalemia. And we know that in our heart failure patients, at least 40% and probably 60% of people have some renal dysfunction. So our patients with heart failure have major renal disease. And I'll come back to this through my presentation. Really important that heart failure patients have renal disease, and the kidneys are vitally important in regulating potassium levels. Also, the bowel in heart failure is also often abnormal. We often talk about the heart and the kidney, the cardiorenal axis, but actually the bowel is a very large organ, which is often majorly affected in heart failure. And the bowel is also incredibly important for potassium homeostasis. So I think in this context, we need to think about the heart, the kidneys, and the bowel. And of course, whenever cardiologists think about hyperkalemia, we always think about our drug therapies. And of course, our vitally important drug therapies include agents which increase potassium, particularly MRAs, ACE inhibitors, and ARBs. I'm going to come back to that through my presentation. But also there's some other vitally important systems which regulate potassium, which we focus on in heart failure for other reasons. And these are neurohormonal systems such as the renin-angiotensin-aldosterone system, but also the sympathetic nervous system, and also regulators of acid-base balance. So if we think about how common hyperkalemia is in heart failure, we have some great data to look at. First of all, looking at the Danish national data, this is these fantastic data the Danes have that cover their whole population. They've looked at how common hyperkalemia is in heart failure. You see that about 40% of people with heart failure with with heart failure have a potassium above 5 over a two-year period. If we raise the level of potassium to greater than 5.5, it's about 15%. And if we look at potassiums over 6, it's about 8%. So certainly hyperkalemia is common if we look across countries. And again, we've heard from Professor Fishbein about risk factors for hyperkalemia, and we constantly see this issue with chronic kidney disease, people with diabetes, and MRA use. So these are the people we need to be especially vigilant about. So turning to a slightly different population, again, this is a very large study from the United Kingdom, looking this time not at everybody with heart failure like the Danes did, but newly diagnosed heart failure. We can see about 11% of people developed hyperkalemia over 3 years. So really common. We're looking at everybody with heart failure in Denmark, and also common in new onset heart failure in the UK. So again, this is fascinating. Professor Fishbein showing us the Dialyze outcome trial in dialysis patients, looking to see if we can reduce cardiovascular outcomes. And classically at medical school, we think about hyperkalemia causing abnormal ECGs, the tall peaked T waves leading to ventricular arrhythmias. But I think it's fair to say that hyperkalemia does have, is associated with many problems with respect to cardiac function and rhythm. So really important for the myocardium, lots of different functions, and also rhythm, atrial and ventricular arrhythmias. But way beyond this, we've seen some very elegant studies looking at important cardiovascular issues, such as coagulation, platelet function, really important and highly influenced by potassium levels, and also things like endothelial dysfunction. So perhaps there's a relationship with coronary artery disease and acute atherothrombotic events in the coronary arteries and elsewhere in the body. So let's really think about why hyperkalemia is a problem in cardiology or in heart failure and the various different mechanisms. Let's move away from just thinking about ventricular dysrhythmias. Again, Professor Fishbein showed a similar slide looking at what level of potassium might be dangerous. And this is a slide particularly in heart failure from a population by Fayaz Zaned a couple of years ago. And again, this highlights if we go above 5, the risk of cardiovascular events climbs pretty highly. And again, if we go beyond 5.5, really the level increases fairly dramatically. And the feeling is if we use potassium binders, perhaps we can decrease this risk back to the lower levels of potassium. So again, a really important issue I want you to think about is hyperkalemia a risk factor or a risk marker for mortality? And there's been lots of really high caliber publications addressing this recently. And looking at the Biostat heart failure registry, they in fact found that hyperkalemia was not an independent risk factor for mortality. And a similar finding from the Swedish heart failure registry, that hyperkalemia wasn't an independent risk factor for long-term mortality. But really importantly, and I'm going to stress this, that certainly hyperkalemia is an independent risk factor for cessation or stopping of MRAs. This is a key issue when clinicians, heart failure clinicians, cardiologists see high potassium. Often their response is to stop or decrease MRAs. And I'm going to explain how important MRAs are in a second. So again, hyperkalemia, this issue with hyperkalemia, is it a clinical problem? And really the issue is stopping or pausing inhibitors of the renin-angiotensin-aldosterone system. And this is not just MRAs, also ACE inhibitors, angiotensin receptor blockers, and of course, sacubitril valsartan, which is this compound which marries sacubitril, the neprilysin inhibitor, with valsartan, angiotensin receptor blocker. And if we think about why we stop or pause these drugs, quite often it's for what's perceived to be acute kidney injury. I think we've all become very aware over the last few years that this is often really not a good reason to stop these agents. We often see a small reduction in eGFR when we start these drugs, and we know that they actually have beneficial effects on renal function in the medium to long term after that very short period of a decline in eGFR. So let's not stop these drugs for minor fluctuations in renal function. Hypotension can be a reason for stopping these drugs, but hyperkalemia is a common reason for stopping these drugs. And this is what we really want to focus on and think about using potassium binders to stop clinicians from stopping life-saving therapies for heart failure. So a really fascinating publication. This is a really influential paper which has impacted clinical practice around the world. And this was data from Canada when they looked at the instance of hyperkalemia requiring dialysis following the publication of the RAIL study. So of course, the RAIL study showed that spironolactone used to treat heart failure had major benefits. But following that New England Journal publication, there was a widespread increase in the prescription rates of spironolactone. And this led to quite a lot of increase in hyperkalemia and serious hyperkalemia requiring dialysis. But when we looked back at these data, in fact, these were inappropriate prescriptions of people who didn't have heart failure and people getting the wrong message. So please don't be put off by these data. These data reflect inappropriate use of spironolactone following the RAILS trial. If we use spironolactone in appropriate heart failure patients, we have major benefits. So again, just to focus even more on this issue of MRAs and hyperkalemia, the Swedish have done a really fantastic study looking at new users of MRA and looking at when new users of MRAs, so spironolactone and eplerenone, and what happens when they develop hyperkalemia. And the Swedes found that when people on MRAs developed hyperkalemia, about half of the patients had their MRAs stopped, and another 10% had the dose reduced. So about 60% of people on MRAs with hyperkalemia had their MRAs either stopped or reduced. And when the drugs were stopped, 75% of them were not restarted again. So this is a big issue. If you ever think about stopping an MRA, stop to think, is it necessary? Can I do something else about it? And this is the key role of potassium binders in the management of heart failure. So looking at the RAILS trial, I've already said the RAILS trial was this trial which randomized people to spironolactone or placebo with heart failure, with advanced heart failure, ejection fractions less than 35%. And this showed that spironolactone certainly does cause hyperkalemia. If we look at the rates of hyperkalemia above 5, we see that 51% of people had hyperkalemia as opposed to about 28% with placebo. If we look at how often people on spironolactone developed a potassium above 5.5, it was about 20%, and above 6 was around 4%. So certainly spironolactone does cause hyperkalemia. We can look at similar data from the eplerenone trial, Ephesus. Now we look at the RAILS trial and see what the independent predictors of hyperkalemia were in this population of severe heart failure. You see this consistent message. So again, MRA, spironolactone, is the major cause of hyperkalemia when you use this drug in this population. And also the other issues we've talked about, renal disease and diabetes, also being important. So we need to be vigilant and focus on MRA prescription in these patients. Again, just for maybe for the non-heart failure specialists, the people that aren't very familiar with the RAILS trial, let's remember how important MRAs are in heart failure. This is a ridiculously important drug. So a 30% reduction in mortality with spironolactone in heart failure in the RAILS trial. So we must make every effort to initiate spironolactone in people with ejection fractions less than 35%, the RAILS-like population, and also to maintain it. So really important, and this is where potassium binders will be of use. As people put on spironolactone who develop hyperkalemia, this is when we should be thinking of using potassium binders to maintain people on spironolactone. This is the Ephesus study. Again, people with ejection fractions less than 30% using eplerenone. You can see again this major benefit, this time 37% reduction in cardiovascular death or hospitalization for heart failure. So sometimes when nephrologists or general clinicians see somebody on MRAs for heart failure, they wonder why we're so enthusiastic about maintaining the MRA. This is because we've got such dramatically improved outcomes with MRAs in heart failure. And it's not just MRAs, I've already said, ACE inhibitors already, ACE inhibitors can cause hyperkalemia, but we need to make every effort to keep people on ACE inhibitors because of this major benefit. This is the consensus study, enalapril against placebo, showing a 40% reduction in mortality. So really quite amazing. And again, sacubitril/valsartan or Entresto is now a very commonly used therapy in heart failure. We know that sacubitril/valsartan is even superior to enalapril in heart failure. So we must not stop these drugs when we see hyperkalemia. We need to really maintain these drugs and not lose the benefit for the patients. And again, these drugs, so MRAs, ACE inhibitors, sacubitril/valsartan, are now the absolute cornerstone of management of heart failure. So we all know now that we don't go through the stepwise initiation of ACE inhibitors, then beta blockers, then MRAs, then switching to sacubitril/valsartan. We get all these people on the drugs, all these class 1 recommended drugs as soon as possible. And if hyperkalemia gets in the way, we need to think about potassium binders. Again, the magnitude of the benefit of modern comprehensive heart failure therapy is shown in this slide. This compares people with MRAs, sacubitril/valsartan, beta blockers, and SGLT2 inhibitors against people only receiving ACE inhibitors and beta blockers. You see, using modern comprehensive therapy, a 50% reduction in mortality and 70% reduction in heart failure hospitalization. So using all of the modern drugs is important. And if hyperkalemia gets in the way, we need to think about treating it with novel agents. So again, further data to emphasize the benefits of MRAs. This looks at people who have had their MRAs discontinued. So people with heart failure who've had their MRAs discontinued or down titrated. You see the mortality rates are about 2.5 or even 3 times greater than those who are maintained on MRAs. So it's really not a good idea to be stopping or reducing MRAs. And remarkably, if we look at national registry, this is data from the States and the CHAMP registry, you would think that 90% of people on MRAs, no, they're not. It's about 35 to 45% of people who are on MRAs. So these drugs are dramatically underused, really inexplicably underused in heart failure. So why might people not use MRAs? Maybe they don't know the data, maybe they're not aware of the major benefits their patients get from these drugs. Maybe it's cost. I don't think so, because MRAs are very cheap, they're inexpensive. Perhaps they're being managed by non-specialists who don't focus on giving them the right drug. Or perhaps it's hyperkalemia, or perhaps fear of hyperkalemia, and we should discuss this, or renal dysfunction. So again, moving to how do we treat hyperkalemia and heart failure, Professor Fishbane's very clearly told us how to do this in terms of non-pharmacological ways. Certainly we eliminate potassium supplements, and it's amazing how many heart failure patients are taking oral potassium supplements. We stop these. And dietary advice, as Professor Fishbane said, is important. And it's something we don't do well or at all, in fact, in cardiology practice. So I think we need as cardiologists to think about potassium diets, and we need to learn from the renal pharmacists. So our heart failure nurses, our heart failure pharmacists, our cardiologists need to learn about how to decrease potassium-rich food. And I understand in Saudi Arabia, there's a lot of date consumption, and dates have got a very high concentration of potassium. So again, we've heard about Lokelma already. So Lokelma or SZC, we've heard about Lokelma. I won't go through this again, but just to highlight, this is not systemically absorbed, it's all in the bowel, very high affinity for potassium and exchanges for sodium and hydrogen. And again, this rapid onset of lowering potassium, which Professor Fishbane has emphasized. So really important for cardiologists. We're simple people. You give SZC and we see a quick lowering in potassium within an hour. So really impressive. What about Patio? We should talk about Patio is also available. So Patio binds potassium ions, again, large in the large intestine as opposed to Lokelma, which is across the whole intestine, and exchanges for potassium ion, for calcium ions. And we know that the onset of action is slightly slower than Lokelma, roughly about 2 to 7 hours after administration. So what about recent guidelines? We've seen the 2021 European Society of Cardiology guidelines, which state that Patio or SZC are effective in normalizing potassium levels, maintaining normokalemia over time, preventing the recurrence of hyperkalemia. They should be considered for the treatment of hyperkalemia. This is a table which I'm not sure if you've seen very often. It's actually a table in the supplement of the ESC 2021 guideline, which addresses hyperkalemia in quite a lot of detail. And these are remarkable recommendations. So the people with potassiums greater than 5, less than 6.5, not on maximal tolerated guideline therapy, it says the potassium lowering agents or potassium binders should be initiated. So really, really clear recommendation, and we can maybe discuss that. The second recommendation, patients with potassiums greater than 5 or less than 6.5 on maximal therapy, treatment with a potassium lowering agent or binder may be initiated. And people with potassiums who are very high, greater than 6.5, again, you can start a potassium binder. So this is table 24, in fact, of the ESC 2021 guidelines. I've not seen much discussion about this, but maybe we can discuss this later. So now I'm going to look at the trials in heart failure. So Professor Fishbein showed you the trials across disease areas, and these trials in dialysis patients or chronic kidney disease. Pearl-HF is the first one I want to talk about, which is a Terramere study studying 105 patients with heart failure and hyperkalemia, resulting in discontinuation of renin-angiotensin-aldosterone system inhibitors, randomized to Terramere or placebo, and titrating spironolactone to 50 milligrams. And not surprisingly, people with Terramere had less hyperkalemia, 7.3, against placebo, 24%, and more people achieving 50 milligrams of spironolactone. Again, the Amethyst study was a diabetic nephropathy study, but included 105 heart failure patients. And you can see the reduction in potassium with Terramere in this study. Also notably, there was some reduction in magnesium in 1.2% of patients, which again, we might want to discuss later. What about the evidence for SZC in heart failure? And Stephen showed you the data from the Harmonized study as a whole, but looking at the heart failure populations in a Harmonized with 87 heart failure patients with a potassium greater than 5, you can see this rapid reduction in potassium over really a very few number of hours, seen in the first hour. But certainly within the first 4 hours, we saw this really dramatic reduction in potassium. And with Lokelma, we saw 93% of people had a potassium less than 5 in 48 hours. When we looked at edema, and edema has drawn some attention with Lokelma in heart failure, with the 5 milligram dose, we didn't see any edema. With the 50 milligram dose, we saw 14.3% of people with edema, as opposed to placebo, 2.5. So what about practicalities? And cardiologists are simple people. How do we use these drugs? So Terramere is 8.4 grams orally once a day as an initial dose, with maintenance dose between 8.4 and 25.2. These are quite difficult to remember, which is important for initiating new drugs. And this really important point for me personally, for my colleagues, my pharmacy colleagues, nursing colleagues, and cardiologists, interactions with other drugs, and Stephen showed this, you're supposed to avoid taking other medications by mouth within 3 hours of Terramere, which is very difficult for heart failure patients. If we think what we ask our patients to do in the morning and the afternoon with heart failure therapy, having a window without medications by mouth of 3 hours is a big deal. So this is quite important. So for me, the dose is difficult to remember, and also the interactions with other drugs. The Lokelma or SZC, the correction phase, 10 grams 3 times a day for up to 48 hours. And as we've seen in Harmonize, we achieve normal kalemia in almost all of our patients, with a maintenance phase of between 5 and 10 a day. And again, with Lokelma, you can take these with other medications, with or without food, and no special conditions for storage. So certainly easy to give. This is a really important time for data with respect to potassium binders. And all of us are looking forward to the Diamond trial results, and we're going to see these over the next few weeks. The Diamond trial is going to publish over the next few weeks. This trial, this is original study design, 2,400 patients with heart failure and reduced ejection fraction and hyperkalemia or hyperkalemia in the last 12 months, resulting in reduction of renin-angiotensin-aldosterone system inhibitors, as well as a hospitalization for heart failure or urgent heart failure visit within 1 year. Randomized to Terramere or placebo, the primary outcome of cardiovascular death or cardiovascular hospitalization. I won't go through the secondary outcomes. But unfortunately, during COVID, this trial design had to be changed. The investigators found that the event rate was much lower than it should be, and there were many issues with respect to COVID that interfered with the conduct of the trial. So they changed the primary outcome measure to a mean change from baseline in serum potassium levels. So we're going to see the detail of this study shortly. And there are many patients enrolled. They didn't enroll the number they intended to, but they enrolled quite a lot of people. I can't give the details, but quite a lot of people. There's also another ongoing trial of Patio in heart failure. This is a UK-specific trial of 2,000 patients with heart failure and clinical congestion within the previous 10 days on quite a lot of furosemide, so greater than or equal to 80 milligrams orally or IV. And this trial randomizes to spironolactone 50 against spironolactone 200, so quite different for cardiologists, with Patio. Primary outcomes, congestion index, composite of time need for intravenous diuretics or non-cancer death and rehospitalization or death. So another interesting trial. With respect to ongoing Lokelma or SZ3 trials, there's this trial called Realize K, very, very interesting, very clearly designed trial. 265 patients with heart failure and reduced ejection fraction, either those with hyperkalemia or at risk of hyperkalemia on less than 25 milligrams of spironolactone, randomized to SZC or placebo, and titrated to 50 milligrams of spironolactone in either arm. Primary outcome potassium between 3.5 and 5, while on spironolactone greater than or equal to 25 milligrams daily. So again, just before I finish, I want to emphasize some strong data with respect to heart failure management and hyperkalemia. We know that sacubitril/valsartan does result in less hyperkalemia than placebo, than enalapril in MRA-treated patients. So if you've got somebody on spironolactone or eplerenone, they're less likely to have a potassium of greater than 5.5 on sacubitril/valsartan than enalapril. So don't forget, there's a good reason to use sacubitril/valsartan in people with high potassiums. And also dapagliflozin as well. If we look at dapagliflozin compared to placebo, we see less hyperkalemia. And by hyperkalemia in this context, I mean greater than 6 in people on MRA, so spironolactone and eplerenone. So hyperkalemic patients make sure they're on sacubitril/valsartan and dapagliflozin for all of the other reasons as well as this reason. So in summary, hyperkalemia is certainly common in heart failure. Optimizing medical therapy for heart failure is core cardiology. Everybody must do this. Potassium binders can allow us to use MRAs or sacubitril/valsartan or ACE inhibitors. So we should think about this as part of our weapons for managing heart failure patients. We have some interesting trials that are ongoing and awaited. And I think future trials should also think about hyperkalemia in HFpEF. None of the trials so far have done that. I think HFpEF, lots of renal disease, lots of bowel disease, lots of ACE inhibitors, really complex issues. So I think HFpEF we should certainly pay attention to from a hyperkalemia standpoint. So thanks for your attention, and I'm really looking forward to the discussion section.
Thank you, Professor Mark. Really, as usual, a very comprehensive and straightforward presentation. We have a lot of questions coming for the audience, for you, Professor Mark, and for Professor Stephen as well. And they are already thanking you and Professor Stephen for the wonderful presentations. So let's start with the questions, because actually we have a lot of questions. First question for Professor Stephen. The first one is asking about the use of Lokelma with the insulin and dextrose to treat hyperkalemia in emergency. Can we use Lokelma with the insulin and dextrose in the ER for hyperkalemia patients?
Yeah, right. Thank you for the question. So there actually was a study published in which it was used acutely with insulin and glucose. So the answer is yes, you can use them. You can combine them. I think it's, an interesting approach. In our health system, we are doing that. So thank you for the question. It's a good question. Has been done, and if you do a literature search, you will be able to find a study that shows what the results were with the combination.
Yes, thank you, Professor Stephen. Professor Mark, also, if you like to comment on this in your practice.
Yes, I think it's a really important issue because it's always one of the very challenging scenarios we see in hospitalized patients with hyperkalemia. And certainly in the UK, in clinical practice, we quite commonly see people giving insulin and dextrose for severe hyperkalemia. And what we see is they then check the potassium shortly afterwards, maybe an hour afterwards, and then they leave the patient for 6 hours, 12 hours, 24 hours even without doing another potassium. So I think these agents are incredibly helpful because they do allow reduction of potassium, because insulin and dextrose causes a very transient reduction in potassium as the as the potassium goes into the cells. But again, as soon as you stop it, if you give a bolus, it really hardly works at any time, because obviously the potassium comes straight back out the cells again. So for me, this is a really valuable role of potassium binders, and particularly Lokelma. So again, I'm sure Professor Fishbane shares my frustration about the management of hyperkalemia. I'm sure it doesn't happen in Saudi. I'm sure that you guys manage hyperkalemia perfectly, but I have seen countless fairly strikingly suboptimal management of hyperkalemia in inpatients. So I think this is a real strength of these agents personally, and I think we should really be talking about these agents in the acute context as being very helpful, because as we see from studies like Harmonize, we see really convincing reductions in potassium to safe levels fairly quickly. And often that's very helpful for 48 hours, because then you can correct the fluid status of the patient. You can stop agents like supplemental potassium. You can look at the patient, optimize them, and see if you can get the potassium down by a whole variety of routes while you have that first 48 hours. So I'm sorry for that quite long answer, but I think it's a really important and something which can really make patients' management better, is to think about the use of these agents in the hospitalized situation.
Thank you, Professor. Professor Stephen, we have another question for you. One of our audience is asking, can I liberate potassium food restrictions for my patients if they are taking potassium binders?
Yeah, thank you, for this question. Almost sorry that the questioner is anonymous, because I think, this one gets to one of my real points of interest. So we have been fascinated by the subject that for both with people with advanced chronic kidney disease, as well as people who are on dialysis, we restrict the diet, and we do so in a pretty stringent fashion. But remember, the foods that we're taking away from patients are generally vegetables, fruits. I mean, these are foods that are some of the healthiest and most enjoyable foods that people consume. In terms of health, the vitamins, antioxidants, phytonutrients, the fiber that these foods contain, it's just so, I think, difficult for patients. But then we start to learn this other information, that it turns out that a lot of these foods actually they have a lot of potassium in them, but we're learning more and more that they really don't cause an increase in potassium concentration. And there's effects on bicarbonate that are really important here as well. So this has been an area of great interest. So really the question specifically has to do with, can you use a potassium binder and liberalize the diet? So this is something that I do all of the time. So in the study that I showed you before, which was our 52-week study, we gave no instructions to reduce potassium in the diet. And for a lot of patients, they really took advantage of that. And there's one moment that I remember very, very well, which was one of my patients coming into the office for a study visit with a bag of oranges. And oranges have a lot of potassium in them. I'm not sure that they really cause an increase in serum potassium, but he was bringing the oranges for me, but he was explaining to me how much he loves oranges and has loved them throughout his life, and was back to eating them again as part of the study. So I think it's really important. Now, I'll note the fact that, unfortunately, we were just about to start a study called the GRAZE study, which you can still find on clinicaltrials.gov, which was using Lokelma in dialysis patients with liberalization of the diet to allow people to eat what they want, to increase potassium intake, specifically through healthy foods, specifically through fruits and vegetables, and using Lokelma to be able to manage potassium. As it turns out, the study is not actually going to take place, but I love the question. Thank you for asking it. And although there aren't studies yet published on this subject, I will say that in my clinical practice, and in our health system, we've had over 11,000 patients treated with Lokelma. In my practice, which is certainly not 11,000 patients, but very extensive use. I liberalized the diet widely with patients. We give them counseling in terms of the right types of food, in terms of potassium, and get just tremendous gratitude from patients being able to eat these foods that they really enjoy a lot again, and that are very healthy as well. So thank you for the question.
Thank you, Professor. Thank you very much. So actually, it's very tangible for us in Saudi, because, you know, in our culture, we have our food is rich in dates. So this will be very, very tangible and helpful for the patients for sure. Thank you, Professor. So, Professor Mark, we have one question for you. What is the lowest level of potassium to start Lokelma in heart failure?
Yeah, thanks for the question. The answer to that is 5.0 in most of the clinical trials. I think all of us as clinicians need to discuss when we think we should be starting potassium binders. Stephen showed some data in populations where perhaps the rate of events goes up at 5.3 or perhaps 5.5 or perhaps higher. So I think all of us need to think about exactly when we're concerned about high potassium and when to initiate potassium binders. But the answer to the question is 5.0 according to the clinical trials. And again, the ESC guidelines, which I showed earlier, also specify 5.0 as well. Although I think it is worth discussing those guidelines, because they were the table I showed was table 24 and was in the supplement. So I would be happy to hear particularly Professor Fishbein, but also the attendees' opinion about that. But 5.0 is the technical answer to the question.
Professor Stephen, what's your reflection as requested by Professor Petri?
Yeah, so I don't think there's a right answer to this question. I think stylistic. I think it's something that individual clinicians can decide. And I think, look, sometimes this is an area that you really need to individualize given some of the characteristics of patients, level of kidney disease, what you know. And I think this is really important, and we don't talk about it as much. We just completed a study of longitudinal potassium concentration. So when we take care of patients, we actually learn about what their potassium exposure is, for example, over the past year, let's say, and we use that in decision-making. One of my researchers in my group is using artificial intelligence to try to get at it. That's a little bit beyond my sophistication. I just look, what are the potassiums over the past year? And I kind of make a judgment based on that. Do I want to start at 5.5 or 5.0? Not necessarily the right answer, and I agree with Professor Petri.
Thank you, Professor. So we have other part of the question from Professor Abdel Fattah. What is the highest level we can treat with Lokelma? Is there a seeding? Is there a level of potassium we should consider as the maximum level of potassium that we should think when to start Lokelma?
So I'll take a stab at this. So the question is about the highest level of potassium, and thank you for asking the question. So if a patient has a potassium that they're running that is 5, 5.5, even 6, 6.5, I'll start the patient on Lokelma. I will treat the patient, talk to them, and try to understand their overall potassium exposure, make sure that they're okay, that there's no muscle or cardiac issues. I want to be really careful here, though, and really want to hear Professor Petri's thoughts on this, that when the potassium level is getting up above 6, you really have to use judgment. And at some of the higher levels, there really is important acute risk to patients. And that's where I don't think it's just give a prescription to the patient, start them on the medication. You really need to think there about the acute need to lower the potassium concentration more abruptly. I will say that we have been trying to avoid emergency department visits during the latest very difficult surge of COVID in the United States. So I will say, I mean, I've had patients with potassium levels of 7 that we've given Lokelma to abruptly. We teach them how to use it over the next 24 hours. But generally, to your question, I think there is a level that is high enough that you've got to make a decision. Do you need acute treatment rather than just starting chronically? And, Mark would definitely love to hear your thoughts on this one.
Yeah, I think I agree with you. It's a very individualized approach to very, very high potassiums. For me, I agree with you entirely. The other thing is the trajectory of the potassium. So if the potassium has been fairly normal, and then within a few days, it's very high, I wouldn't be relaxed about that at all. I would be bringing the patient in for acute treatment in hospital. So for me personally, if I'm being honest, a potassium of up to 6, I would not be concerned about as an outpatient. 6 to 6.5, I'm getting a little bit more agitated. I'd want to see the patient fairly often as an outpatient. Above 6.5, I'm getting anxious. There's also things like ECG changes as well as trajectory of the potassium, so if it's rapidly rising or staying the same as it's been. So that there's many factors, and looking at the individual patient is generally how we do things as clinicians. But certainly above 6.5 as a cardiologist, I wouldn't be managing the patient as an outpatient in a relaxed way with a potassium binder. I would be bringing the patient into hospital. And again, I think, Stephen, it's worthwhile emphasizing collaboration. And I know this sounds a bit overly friendly, perhaps, but we do talk to our renal physician colleagues, because again, when does somebody need dialyzed? What is the fluid status of the patient? We really need to think about these patients together, because hyperkalemia usually occurs in the context of heart failure and chronic kidney disease. And usually these people with very high potassiums have got eGFRs, which are pretty low. And we should be putting our heads together thinking, why is the patient got cardiorenal disease, and how should we be managing the patient? But certainly potassium binders are useful. I think they're particularly useful in the region of high 5s to 6 to 6.5. And above that, we need to be thinking about other treatment strategies.
Thank you, professors. Another questions, and we can start by you, Professor Stephen. How long can I keep my patient on Lokelma?
Right. So in what we called our 005 study, this was a 52-week study. And over the course of 52 weeks, I will say it was very, very easy in this study to continue patients. It was an open label study. So placebo-controlled studies are a little bit harder, but in some ways, this was really helpful in terms of understanding the real life treatment, because we had a population of patients treated over the course of 52 weeks. We enrolled a lot of patients actually in the study. And I would say that it's really easy to get patients started, to follow them over the course of time, and at least for 52 weeks, we certainly saw very good preserved efficacy and tolerability for the agent. So it probably is true that you can treat patients chronically over the long course of time. But, I'm a little bit funny on this subject of medications in general. I, try really hard with patients to reassess medications over time. So Lokelma has been very helpful for me in terms of being able to especially get rid of potassium as an issue and use angiotensin receptor blockers and ACE inhibitors effectively. So I do use it for long-time treatment, but on the other hand, I do like to every 6 months or so, just kind of take a look and see whether, like any other treatment, we need to be continuing. So, I think it's the better answer to your question is yes, you can use it chronically. It seems to be very well tolerated, very effective over the course of time. And I do recommend, though, with all medications, that we evaluate on an ongoing basis.
Thank you, Professor Stephen. Professor Petri, we have Dr. Gamal is asking about would more use of ARNI and SGLT2 inhibitors in heart failure affect the burden of hyperkalemia? I think in the last couple of slides in your presentation, you covered this issue. But if you want to answer this question for Dr. Gamal.
Yes, again, so thanks for the question. And I think it's really important that we use our heart failure therapies as often as we should for our patients. And the answer to the question is yes. If we use SGLT2 inhibitors, particularly dapagliflozin and sacubitril/valsartan or Entresto, we see less severe hyperkalemia. So I think there's no doubt about that. These are large trials with many thousands of people, cumulative about 14,000 people. So we categorically can see we see less hyperkalemia, but not they reduce hyperkalemia. They don't eliminate hyperkalemia, so we still have an issue. But I would always encourage everybody to manage people with heart failure and reduced ejection fraction with SGLT2 inhibitors as standard therapy, as well as sacubitril/valsartan and beta blockers and MRAs. So it's not the main reason we prescribe SGLT2 inhibitors or the main reason we prescribe sacubitril/valsartan, but it's very useful, additional beneficial effect that we see with these agents. But again, this should be standard therapy. I think Saudi is leading the way in quadruple comprehensive therapy for heart failure with reduced ejection fraction.
Thank you, Professor Mark. Professor Stephen, one of our audience is asking about when do you expect to publish the result of the outcome trials? I think the Dialyze outcome and as Professor Petri mentioned, the Realize studies. When do you expect they are going to be published?
Yeah, so there's a few really important studies that are ongoing right now. It's going to be a while. We expect to be fully enrolled for Dialyze outcomes by late summer, but it's an event-driven study, so I don't think you're going to see the results over the next year or two. When they come out, though, I think it's going to be really important in terms of understanding hemodialysis patients, learning about potassium, and the ability to use Lokelma to, I hope, reduce some of these issues that we get around some of the bradyarrhythmias and other arrhythmias that our patients suffer from.
Thank you, Professor. Professor Petri, one of our audience is asking if a patient is known for recurrent hyperkalemia, should I start a potassium binder with ACE inhibitor or ARP at the beginning before even hyperkalemia occurs?
Yeah, I'll just add to Stephen's comment about the trial. So Realize K, I'm involved with Realize K. And again, it's we don't know exactly when it's going to finish, but probably 2024 is probably our best bet. So that'll be fascinating to see the data from Realize K. So with respect to people with recurrent hyperkalemia and whether or not we treat with ACE inhibitors or ARBs and wait for hyperkalemia, or we start the potassium binder before we initiate these drugs again. Again, I think that's an individual decision for clinicians in the context of the patient. But if somebody's already been on ACE inhibitors or ARBs several times and had consistent hyperkalemia that concerns a clinician, it makes sense to me to start the potassium binder before you initiate the ACE inhibitor or ARB. But again, the clinical context important. So if the patient was started on an ARB and they were dehydrated and they had hyperkalemia, then I might not. So I think you have to look at the clinical context of the hyperkalemia before perhaps the patient's more stable than they were previously. Maybe they were hospitalized, now they're an outpatient. So these things that doctors and clinicians do every day, I would be looking at the patient. But certainly if the patient's had hyperkalemia they were in a chronic, stable outpatient environment, and they were on ARBs or ACE inhibitors, I think it'd be reasonable to start the potassium binder. But to be honest, in my usual practice, I would usually have the patient on the drugs and wait for the potassium to be elevated before I start the potassium binder. But I would understand both approaches.
Thank you, Professor Mark. Professor Stephen, does the incidence of hyperkalemia is different from spironolactone to finerenone?
So this, I think is a very acute question right now. 2 years ago at the American Society of Nephrology, George Baccaris and Rajiv Agarwal presented the results of the Fidelio study and suggested that finerenone may cause less hyperkalemia than's been seen with spironolactone, and just very recently published a post hoc analysis in which they looked at the risk for hyperkalemia, specifically though with finerenone in their study compared to placebo. So what we don't have is a direct comparison study between finerenone and placebo. So, two questions I'd like to bring up, because there's a lot of discussion that's taking place that finerenone causes less hyperkalemia. Let's hope that that's true, because that would be a very good thing and good for patients. But one, as we saw from Professor Petrie, as we looked from the initial spironolactone studies, like the RAL study, where there wasn't a lot of hyperkalemia, then over the next couple of years, people published studies on real life experience, and there was quite a bit of hyperkalemia. That would be one concern I would have with finerenone until we understand this a little bit better. The second is, I do have to remind you that they studied a population of patients who were really optimized already on ACEs and ARBs and had potassium levels of less than 4.8 at entry. So it's a population of patients where those that might be at risk for hyperkalemia were not included in the study, or of course in the post hoc analysis. So I'm not sure that we can really make inferences in terms of hyperkalemia risk with finerenone compared to spironolactone yet. Let's hope so, because I think it would be good if there's less risk. I don't think we have nearly enough information to know if that's true yet.
Yeah, thank you, Professor Stephen. We have two questions actually on the same topic. It's asking about, in your clinical, this is for both of you, Professor Mark and Professor Stephen. In your clinical practice, how often do you see edema with Lokelma? The other part of the question, what is from Dr. Abdel Fattah, what is the explanation of edema? If it is due to the sodium retention, does this raise a red flag for worsening of heart failure? Professor Mark, if you can start on this.
Yeah, so that's a good question to discuss, and certainly in the trials, which are not big trials, we have seen some edema, but that was with the higher doses of Lokelma, so 50 milligrams, and really with the smaller doses, particularly 5 milligrams, 10 milligrams, we haven't seen. With 5 milligrams, we haven't seen edema, and with 10 milligrams, not very much. So the question is a great question, and what we're doing in Realize K is we're addressing this question head on. So in Realize K, when somebody gets edema, we are looking at it in a very systematic, very organized way, and we're performing lots of investigations with respect to whether or not it does reflect fluid retention or cardiac dysfunction or heart failure. So we're doing end-terminal pro-BNPs and a fairly comprehensive heart failure assessment. So the answer is, in clinical practice, the lower doses, we don't see edema, but we are very keen to make sure it's not a clinical problem. And we're conducting Realize K in a really robust way, making sure we perform an absolutely comprehensive, detailed assessment of everybody who has edema. But I'd be keen to hear Stephen's opinion about this as well.
Yeah, you know, I think I agree so completely that I'm not sure that I can really add much. I would like to say, though, from my experience, which is interesting because I'm treating patients on hemodialysis. So a lot of these patients have zero urine output. And from the very beginning, we've been really concerned about this population. And yet, as you saw the data that we presented before, that in the Dialyze study, now it was only 2 months of treatment, but 2 months is a very reasonable period. If you're going to get sodium accumulation, you will see it there. And we really had no problem with edema, with worsening blood pressure. And I think the best measure, which is interdialytic weight gains. And in the current trial, look, it's not a good practice to talk about patients that you're treating in an ongoing study, but I think it's okay for me to at least say this, that, you know, I continue to be interested in the fact that I just don't seem to see edema. That being said, you know, we looked at data before, we saw that in CKD and other populations, placebo-controlled studies, there is edema that occurs. It occurs at relatively low rates, almost none at all compared to placebo at 5 grams. And a lot of patients can be treated very effectively at 5 grams. 64% of the patients in our CKD patient study. At 10 grams, you start to see a little bit more, still pretty low rates. Patients should be looked at. But absolutely, when you get to 15 grams, you will see some patients, 14% of patients in the placebo study compared to 2% in the placebo group. So there is some edema that develops there. At that dose, patients should be monitored and very simply make the adjustments that are necessary if some edema should develop.
Thank you, Professor. Just I would like to mention, adding on what you said, Professor, that we don't have the 15 gram period sound. You know, we have the registered doses only 5 and 10 gram. As you mentioned, there was the lower incidence of edema. Another question, yes, yeah. Another question, Professor, is coming. How often should I monitor for hypomagnesemia with Terramere, especially for heart failure patients, Professor Mart?
Yeah, that's another good question and something which comes up fairly often. So there's no strict measurement regimen of magnesium in heart failure and Terramere. I just pointed it out because it's certainly has been found, again, small numbers, less than 2%, so 1 point something percent in Terramere and heart failure. But again, it's another one of these things which we have to think about, and we all know that hypomagnesemia is associated with ventricular arrhythmias. So I'm keen people are aware of that, and if they are managing somebody perhaps who is demonstrating some increase in ventricular arrhythmias, they should be aware to measure magnesium. So I wouldn't give a strict, for example, 3 weeks, 3 months, every 3 months, that kind of thing, but certainly to be aware of it as a potential issue. But again, we should see some very valuable data from the Diamond trial, which is going to be presented very soon. And I'm sure they will have collected data with respect to magnesium as well as phosphate in the Diamond trial. So the Diamond trial has recruited more patients by far than any other trial so far. So we should see some valuable data to answer that question more comprehensively.
Thank you, Professor Mart. Also, another question for you and Professor Stephen. What was the percentage of Rassi inhibitors in the Lokelma or sodium zirconium harmonized studies? What was the baseline, the percentage of the Rassi users? Maybe I can help them this. I know that.
I think I'll let Mark go.
Professor?
I missed that.
Yeah. They are asking about the percentage of Rassi inhibitor users at the baselines of harmonized study, especially in heart failure patients.
Yeah, there were very high usage of Rassi inhibitors. in the heart failure patients in these trials. I can't remember exactly what they were. Mohammed, maybe you can remind me, or Stephen?
70%. 70%.
Yeah. 70%.
Yeah.
70% from the baseline were using Rassi inhibitors. Yeah. Another question, and this is coming from Dr. Gamal, adding on one slide you showed Professor Petri. He is asking, what are the outcomes trial going to add if the potassium is not an independent risk factor of mortality? You remember the slides we have shown?
Yeah. Very good question. And certainly it's again, I'm really fascinated to know Stephen's opinion about this, but there's been a lot of effort going in to see if potassium is a risk factor or a risk marker, and there's lots of different opinions. Those are just two studies I showed, but I wanted to be as open and controversial as possible. But really, the answer to the question is that the major aim of the ongoing trials is to use potassium binders to enable the use of MRAs, ACE inhibitors, ARBs, and sacubitril/valsartan. So that's the main aim of these trials. So I think the questioner can understand that if we use potassium binders to enable the use of these drugs, then clearly we're very likely to see clinical benefit and reduction in important cardiovascular outcomes. As I repeatedly stressed, we don't have to repeat the trials of MRAs or ACE inhibitors or ARBs for sacubitril/valsartan, because we know these drugs are life-saving and reduce hospitalizations. So if we do trials which are enabling the use of these agents, such as Realize K, is really focused around using spironolactone in people who you can't use spironolactone because of hyperkalemia, then I think the questioner can understand the clinical benefit the patient's likely to receive if the strategy is successful.
Okay, thank you, Professor Mart. Professor Stephen, we have one question asking about the difference between Lokelma, or the advantage of Lokelma, compared to the K-exudate or all the potassium binders.
Yeah, so, I'm going to speak more generally about Lokelma and its role, just generally compared to other agents. So we have other potassium binders that are available. I think one thing that is really clear is that SPS, or Kexalate, as it's called in the US, we really try to avoid treatment with that agent. And there's a few different reasons for that. It's gritty, it's difficult for patients to use. I'm a little bit more concerned just by the fact that it seems to bind everything. It binds a whole bunch of medications, and nobody's ever really studied it to understand the effect that it has on other medications and their absorption. But what we do know is it's a very extensive effect. There is the rare occurrence, of course, of important complications in the intestines that led in the United States for the Food and Drug Administration to put their highest level of warning, which is a black box warning, on the use of SPS. So in our health system, I'm in a health system that has 22 hospitals. We kind of looked at this in terms of our entire health system and made a decision to completely discontinue the use of SPS. And I think that was really kind of in line with the way the Food and Drug Administration, the FDA in the US, looked at it. As these two companies approached FDA, the FDA really wanted to try to get rid of SPS and gave a very easy path towards regulatory approval for both Lokelma and Terramere based on the problems with SPS. In terms of differences, there are differences we can go into between Lokelma and Terramere. We've, in our health system, gone 100% with Lokelma, trying to take advantage of the fact that in the hospital setting, there's two important issues. One, we want to get that acute effect in terms of reducing potassium. So Professor Petri spoke a little bit more about this in depth earlier. In hospitals, this is important, and we want to try to minimize some of the things that we're doing in terms of insulin treatment acutely. That's a separate subject. The other issue is just binding to medications, and our concern is that there are more issues in terms of interactions with Terramere and a wider variety of medications than there are with Lokelma. With Lokelma, it tends to be a couple of medications that are really sensitive to acids, so like Pradaxa or Dagivetran. There's an issue with that medication, but it's just a couple of different medications, whereas whatever you do in the chronic setting, you can talk to patients about drug interactions and get patients to take these agents. So like the issues with Terramere and drug interactions, you can talk to the patient and explain to them how to take the drugs at different times. For our hospital system, that just wasn't tenable. The problem is nurses round at a certain time, they need to give medications at a certain time. And we were really worried that with Terramere, because there's such a large number of medications that are interfered with by Terramere use, that it really wasn't particularly suitable for hospital treatment. So that was a long-winded answer, but essentially it's the way that we've looked at it, and it's how we've gotten to be almost exclusively using Lokelma in terms of treatment.
Thank you, Professor Stephen. Just on the same question, Professor Petri, just to assure the audience, you are asking, Dr. Hussein Shahlan is asking, are all oral medications affected by Terramere use?
No, so it's not all medications, and I actually pulled a slide that I had that showed the specific medications that are affected by each of these, and there's a very sharp difference between Lokelma and Terramere in terms of interactions with medications. It is important to be using Terramere that you do have some understanding of other medications. In the US FDA guidelines, the recommendation is a 3-hour separation between any oral medication with Terramere. Doing that is fine, and you will be able to avoid interactions by so doing.
Okay, Professor. Professor Mart, we have just a couple of questions remaining. One for you, Professor Mark. Dr. Hussein Shahlan is asking, can you explain how Entresto and dapagliflozin lower the incidence of hyperkalemia in MRA-treated heart failure patients?
Yeah, that's Hussein, that's a fantastic
need another
question.
Webinar, yes.
Yeah, so I mean, we've heard many seminars. We've read hundreds and hundreds of articles by lots of people about all the mechanisms of benefit of SGLT2 inhibitors and sacubitril valsartan in heart failure. So we could talk about this for 3 weeks. And obviously we've heard Milton Packer describing the benefits of SGLT2 inhibitors, mechanism of benefit. So I think the short answer is we certainly know both of these agents do reduce the rates of hyperkalemia. I think just to give some very overarching answers to that question, we know that dapagliflozin certainly has beneficial renal effects in the medium and long term, and I'm pretty confident that's one of the mechanisms by which the reduction in hyperkalemia is mediated. If you want to ask me how SGLT2 inhibitors in heart failure have benefits in renal function, that's a whole different question, and we've actually got a paper under review in Circulation where we've done a placebo-controlled trial of empagliflozin, actually looking at the MRI, renal perfusion and things in heart failure, but I can't tell you the results of them because they're still under review in Circulation. But certainly we know the beneficial renal effects, and I'm sure that's part of the deal. We also know that dapagliflozin has beneficial cardiac effects in longer term. So I'm sure the knock-on effects have improved cardiac function, are beneficial renal and bowel function as well as other issues. I'm sure there's a whole multifaceted, multi-mechanism of lowering potassium in heart failure with dapagliflozin. And similarly with sacubitril valsartan, obviously it's a sacubitril part of the drug where we see benefits. And of course, sacubitril, being a neprilysin inhibitor, inhibits the breakdown and increases the levels of ANP, CNP, adrenomedullin, substance P, lots of beneficial things, the GLP-1, and a whole countless range of peptides and other mediators. So the mechanisms of sacubitril reducing potassium are likely again to be many. Of course, we also see with sacubitril valsartan improved renal function compared to ACE inhibitors as well, and I suspect that also feeds into the reduction in the rates of hyperkalemia. So I think both of these drugs generally improve the status of the heart failure patient, and I think the kidneys and the heart and the blood vessels and everything else. So I'm sure there's a whole lot of reasons why both SGLT2 inhibitors and sacubitril as part of sacubitril valsartan reduce hyperkalemia.
Thank you, Professor Mark. One last question today for both of you professors, coming from Dr. Abdel Fattah. Should we continue the oral Lokelma during the acute treatment during hospitalization? Professor Stephen?
Right. So I think that by acute treatment, the question has to do with the acute treatment of hyperkalemia. So if somebody comes into the hospital and needs acute treatment of hyperkalemia and they happen to be on oral Lokelma, we continue it, but instead of once daily, we go to 3 times a day in terms of treatment. In general, though, when we're admitting people to the hospital and they're on Lokelma, we really make a judgment at the point of admission if there's not hyperkalemia present in terms of whether it should be continued or whether it should be held temporarily. But that becomes an individualized treatment decision.
Thank you, Professor Stephen. Thank you, Professor Mark. Actually, it was a very wonderful lecture. We have a lot of questions coming from the audience, and for sure we'll have another opportunity, hopefully having you here in Saudi as our guest and meet our great doctors also here in Saudi face-to-face. But before we close the webinar, Ustaz Noor, if we can run the poll once again to see the audience reflections. So if we can start the poll. So again, how do you see the current gap in hyperkalemia management? There is a huge gap. There is an average gap. We still can manage potassium level with current treatment option. There is no gap. If you remember at the beginning, we have almost the higher percentage that there is a huge gap, and coming after it was the average gap. So what do you think now? The second question, do you believe that there is a current need for chronic potassium binder use in heart failure, CKD hyperkalemic patients? At the beginning, we have 88% of the audience agree that there is a current need for chronic potassium binders. Third question, and I think this was one of the biggest topics we have discussed today through our 2 greatest speakers, Professor Stephen and Professor Mark. Do you see the challenges in optimizing Rassi inhibitor therapy, either in CKD or heart failure patients? Yes or no? Fourth question, do you agree that sodium zirconium cyclosilicate Lokelma, which is now available in Saudi Arabia, provides rapid, sustained, and safe solution for hyperkalemia patients? And if so, I am willing to use Lokelma with my hyperkalemia patients, yes or no? So we have still the same percentage for the first question, but the majority of the audience agree, even more than the start of the meeting, that there is still a gap in the management of hyperkalemia. And we need, as Professor Petri and Professor Fishman said, we need to do more effort. We have the percentage increased in the need for a chronic potassium binder, 94% of the audience. The good news that the majority of the audience, 82%, are agreeing that there is a challenges in the using or optimizing or enabling Rassi inhibitor therapy. The good part that we have 100% of the audience now see Lokelma as the new path, which will provide rapid, sustained, and safe solution for hyperkalemia management. The last point, are you willing to try or use Lokelma with hyperkalemia patient? Almost we have the majority of the audience, 94%, are willing to use Lokelma after its availability in Saudi. So at the end, I would like to thank you, Professor Stephen and Professor Mark, on behalf of our audience. It was a great pleasure having you with us in Saudi. I hope that, inshallah, in the coming meeting, we have you here face to face with our great doctors in Saudi. Thank you, Professor Stephen. Thank you, Professor Mark.
Great. Thank you so much.
Pleasure. Total pleasure. All the best. Bye-bye.